Dear Chairman, thank you. Mano, once again, thank you for this kind invitation. It's really an honor to be a faculty member in this wonderful meeting. So I'll give this talk in English because we have distinguished guests in the room, if you don't mind. The spectrum of surgeries in the shoulder pathology is quite wide, as you see here, but I'm going to address in the next minutes the subacromial decompression, which can be performed alone or in conjunction with rotator cuff repair. So the primary goal of surgeries regarding impingement and rotator cuff tearing is reduction of pain and improved function. Therefore, the main clinical indications for imaging in the postoperative setting is pain and/or disability following surgery. We are all familiar with the shapes of the acromion, the three described by Bigliani, and also a fourth one, the curved one, which was described later on. We know very well that this hook here in the anterior aspect might actually represent not a congenital deformity, but rather an enthesified because of the tension of a thick here ligament, the coracoacromial ligament. This is one part of the history. However, Dr. Hiotis in the previous session mentioned that apart from the shape of the acromion, as we see here, there is enough space behind this rock in Arizona, but there is also a lateral downsloping which matters. We have a way to quantify this lateral downsloping, and this is measuring the relative angle of the acromion to the distal part of the clavicle. If it's more than 12 degrees, then we say that we have to deal with a lateral downsloping of the acromion, and here's the result. You see the slope, you see a thickened here ligament, and the tendon itself is thick and has abnormal signal intensity in keeping with supraspinatus tendinopathy. Apart from the acromion, however, very common causes of impingement are the osteophytes, which are in the undersurface of the acromioclavicular joints, and also large os acromiale. So the subacromial decompression aims at enlarging the subacromial space and includes resection of the coracoacromial ligament, not in young athletes, as previous speakers suggested, because we don't wish the humeral head to migrate superiorly. Bursectomy, acromial resection, osteophyte resection, and distal clavicular resection, known also as Mumford procedure. Here we see the enlarged space postoperatively, and this is the plain film with an excessive distal clavicle excision. So in the acromioplasty and subacromial decompression without any surgery to rotator cuff disease, we need to go either with MRI or with ultrasound for assessing the postoperative patient. MR arthrography is not routinely indicated. Here we see the hooked acromion. If it's removed, we have a flattening here of the acromion without any insertion of the coracoacromial ligament. These are the results here. That's the hook. We have a flattening, and the ligament is gone. We have just a fibrous tissue here, which is loose, no sharp borders. It's not attached to the acromion. That's release of the ligament. So the expected MR imaging findings in the postoperative setting of subacromial decompression are the flat acromial undersurface, the shortened anterior acromion, fibrous tissue underneath the AC joint, and scar and fluid into the bursa. These are not abnormal. These are normal postoperative findings. And now I would like to move on to the larger part of this talk, which has to do with RC repair. The normal findings with X-rays include the assessment of the devices. They have to be intact, not fractured, and they have to be on site. In addition, we evaluate the acromiohumeral distance. This has to be at least 7 millimeters. With MR, we see a lot of bone marrow edema. Here you see the bone marrow edema on fat-suppressed images. It's high signal intensity. It's surrounding the anchors that we see here. We have fluid and fibrous tissue in the bursa. We're not reporting that. This is a normal postoperative finding. We have the Geyser sign, which we'll discuss in a while. And we may have also osteolysis around the bioabsorbable anchors, which is not always important clinically. So what is interesting is that for a couple of months after surgery, we do have an abnormal signal which is very similar to the full thickness tear of the tendon. That's a normal finding. You see in 6 months it's gone. We have a normal tendon here. And in addition, the bone marrow edema, which is persistent here in 2 months postoperatively, it's also gone some months later. These are normal findings. Even the bursitis here, fluid into the bursa, is substantially reduced in the postoperative period. So regarding the devices, we need to assess them if they are intact, if they have migrated, as this one, which has migrated posterior superiorly. We see here also the artifacts with MR imaging, or this one, which has a partial pulled out from the insertion of the supraspinatus tendon. It's important here, particularly for medical legal reasons, to have an immediate postoperative X-ray, because we need to assess if the displacement has been performed intraoperatively or later on, and this is for the protection of the orthopedic surgeons. In addition, synovitis, granuloma formation, and cartilage erosion may occur because of displacement of the devices. A massive retear can be suggested with plain films because of the reduced distance between the humeral head and the acromion, as we see in these two patients. We need 7 millimeters normally. That's the normal one. And regarding the retear, here we have to deal with a lot of normal findings, with a lot of artifacts. For instance, usually in musculoskeletal imaging, we need to apply fat-suppressed images with spectral fat presaturation, as we see here on the left slide. However, spectral presaturation is associated with lots of artifacts. See here how many artifacts this metal produces. And these are called susceptibility artifacts, and we can get rid of them if we apply an old-fashioned stir sequence, which is not as good as this one normally, because it's not able to provide thin slices, but it's not downgrading the quality of the image, because you see the artifact is so reduced that we have a diagnostic image. This is a full-thickness stir. Is this important? No, it's not. Manos mentioned previously that we may have asymptomatic full-thickness retears, and actually 2 good friends of mine from Zurich have published many years ago in skeletal radiology that defects which are less than 11 millimeters are very often seen in asymptomatic patients. So we need to match and correlate the clinical picture with the imaging findings. I'm using the Sugaya classification scheme in order to communicate better with clinicians. So Sugaya 1 shows a normal tendon, low signal intensity, normal morphology. We need to use fat-suppressed images always. In Sugaya 2, we have some intratendinous signal. These 2 stages usually are not symptomatic. We have more symptomatic patients with stage 3, where we have more high signal with some defect in the bursal side. This is a partial tear, whereas in stage 4 with small retraction, and in stage 5 with high-grade retraction of the torn tendon, we do have lots of symptomatic patients. Here is a patient who has been operated 2 years before this imaging. He had a retear because of 8 hours working throughout the weekend in the garden, and we see a retear of the supraspinatus tendon. You can see here that there is a free communication of the fluid with the subacromial bursa and then the fluid enters into the acromioclavicular joint. This is called the geyser sign. It's very helpful in patients who have not been operated because we can assess massive tears with accuracy, high accuracy, but in the post-operative setting, the geyser sign is seen very often. Here we see on fat-suppressed images, coronal oblique and sagittal oblique. You see that the tendon is gone. Here the tendons of the rest of the calf are okay, and there is a free communication with AC joint. In addition, we do see here a Goutallier 4 fatty infiltration at atrophy of a teres minor muscle because of a mistear by both radiologists and orthopedic surgeons 2 years before. Adhesive capsulitis may be seen quite often in the immediate postoperative setting, but it's not clinically important. Yet in a minority of patients, about 5%, it can show some clinical symptoms. It is demonstrated on MR with lack of the fatty tissue in the rotator cuff interval, thickness of the subscapular recess, and the feeling that when we are doing arthrography, we have a resistance after 4 or 5 ml of injection, whereas normally we inject 12 to 15 ml of contrast. The absolute criterion for the presence of adhesive capsulitis is to inject intravenously gadolinium, and we see lots of enhancement in the rotator cuff interval. This is fibrovascular tissue. This is the subscapularis. That's the supraspinatus, and this is the biceps tendon, the intra-articular part. So this is the rotator cuff interval enhancing. And in up to 9% of cases, we may see the biceps tendon migrating from the groove into the fibers of the subscapularis tendon. That's another complication. In other patients, we have more than one finding. For instance, in this patient, we have a wavy appearance because of retraction of the supraspinatus tendon. You see the difference between chemical fat suppression and stir sequence. Lots of artifacts, reduced artifacts. And here we have a dirty synovium, that's synovitis. We have a dirty subscapular bursa, that's a lot of fibrous tissue into the bursa, and we have also a dirty subscapular recess because of adhesive capsulitis. A well-recognized now MR pitfall, which I almost always see, is the presence of contrast after being injected into the glenohumeral joint, into the bursa. That's contrast, injected into the joint. That's a normal finding. It's not suggesting a tear of the supraspinatus, and this has to do with the fact that tendon repair does not necessarily lead to a watertight rotator cuff. So this is a normal finding, no fat suppression. With fat suppression, you see nicely the tendon. That's normal here. That's normal postoperative finding. Infection is another issue, and it's another issue because frequently, we don't have systemic signs in the patient, and if you have any clinical suspicion, then we have to go with image guiding. I use either fluoroscopy or ultrasound to get fluid from the joint in order to isolate the microorganism. But imaging is very important for orthopedic surgeons because we can discriminate between superficial infection, which can be treated conservatively, from deep infection, which might need surgery. So here you see deep infection, a fistula, and infection in the subcutaneous tissue as well. Osteochondral lesions are very important. They may recur from retear dysfunction, instability, device migration. They lead to osteoarthritis. Here you see a displaced ankle, osteophyte formation, a joint space narrowing, which did not exist before the operation. And in the end, we have osteoarthritis, or we might have also, I have seen many cases of secondary synovial osteochondromatosis after the surgery. Chondrolysis in general, that means destruction of the cartilage, results from either thermal devices used during arthroscopy, malpositioning of the devices as we've seen before, and large volumes of intra-articular local anesthetic. That's an important issue, and now we tend to use just 1 or 2 mLs, particularly in arthrograms or therapeutic injections. Sometimes we deal with unexpected findings. 9 years here after supraspinatus repair, we see that there is ossification of the infraspinatus muscle. So last but not least, neurologic complications include the chronic regional pain syndrome or pseudoexalgodystrophy, the old terminology. We see osteopenia, plain films, or bone marrow edema and soft tissue edema on MR. That's a very difficult case to treat. We may have also peripheral nerve injury, usually from manipulations and very rarely by direct laceration as such or entrapment. Many nerves can be involved here, and usually they represent neuropraxias. That means injuries which resolve with time. And here is an example. You see the edema. Compare the infraspinatus with the subscapularis. And the deltoid, this is edematous. This is because of a nerve injury. And another patient with supraspinatus and infraspinatus edema because of injury in the suprascapular nerve, particularly when you use posterior portal placement. Here is the edema in the infraspinatus. And some patients, if it's not resolving quickly and promptly, we may have fatty infiltration and atrophy. This is the infraspinatus, that's the supraspinatus. Goutallier 1, Goutallier 2 in this example. So how I do it, according to my personal experience and also the evidence suggested by the literature, I need radiographs which have been taken because of the current symptomatology, but I would appreciate if I would have access to radiographs which were taken in the immediate postoperative period. If we have few metals in the radiographs, I'm using MR arthrography, and in the end, I'm taking also a conventional oblique coronal proton density with fat suppression because arthrography is not able to assess the intratendinous structure. If there are lots of metals, for instance, 4 metallic anchors, then I prefer the CT arthrography, and in both cases also dynamic ultrasound might be a complementary tool to assess an ongoing impingement. Thank you very much for your attention.